here we are again, doing the thing that maybe we didn't want to do. We didn't want to do this, but we have to. We got to do it again. We are studying cancer. Um, Now, cancer, everyone knows about it. It's not really a very loved thing, but it is something that we need to know about for sure. Um, Cancer causes 1 in 4 deaths, which means that it is the second biggest killer in, let's just say, the US, only to heart disease, which is our #1 killer. But there's a lot of living cancer patients and survivors, so the question that we need to ask ourselves is, like, what is cancer? Um, how does it begin? How do we try and stop it? And what are factors that make the difference? What are factors that we need to really make sure that we get on before the problem becomes kind of over, and the person perishes. Um, we don't need to know which the common U.S. cancers are, but it's important to think about. Just simply because, yeah, new diagnosis is highest one is breast, second prostate, then lung, colorectal, and then melanoma, which we'll talk about kind of about those later on down in the PowerPoint. The number one most common cancer to lead to death is lung cancer, which is not like a crazy thing to say, simply because we are talking about airway, breathing, circulation with that. Colorectal is number 2, pancreas is number 3, breast number 4, and prostate number 5. So what is cancer? It's an important thing to say. Cancer is really scary. Nobody wants to get cancer at all. However, when you do have that cancer, what is it? How does it become what it is? Just trying to take a sip of my coffee before it gets too cold. Cancer is a group of malignant diseases that can be distinguished from benign tumors and normal tissue because of the following characteristics. Cancer is resulted from a gene mutation, okay? Somehow your cell becomes rogue, let's say. It becomes a rogue cell and it says, you know what, I want to do whatever I want. I want to just be whatever I want to be, and I'm going to just change to be whatever I want, right? And I'm going to make a whole lot of me because I really want to be everywhere all at once, okay? So cancer is the hallmarks of cancer stem from an abnormal amount of cell proliferation, meaning the cells are replicating a lot and it's uncontrolled. So not only is, because cells replicate all the time, okay, that's the whole point of skin cells especially are rapidly dividing, okay, but in a cancerous cell that rapid division is rapider, and it's not to the point where it's abnormal. They're being produced at this wild rate, okay? And the issue with that, okay, is that these cells are not built correctly. They have small abnormalities, like structural abnormalities, that practically make them useless to the body. They are simply wasting space and your energy. They are a waste of space, and they want to take over. They want to say every cell in the body should be like this. So these cells they will grow, and they will go, and they are not useful to you at all. And they can invade, which is also called metastasize. They will metastasize to other organs and then start to invade those tissues. Which, of course, the tissues there are like, hello, like you're a skin, like you're a cell that you're not supposed to be here. Like you can't even begin to start doing what I need to do, okay? But this cell doesn't care. The cell is just going to continue to multiply and take up space and can cause a lot of damage wherever it goes. Now, because this is a genetic process, meaning it comes from an abnormality, a mutation in your gene, or in your the gene of the cell, um, there's some reason, like people try to figure out reasons why, people get cancer. Um, there's it can come from a lot of different things. You've heard of carcinogens before. There is a genetic component as well. So could somebody have this from, could somebody get cancer from a whole lot of different factors? Absolutely. There's not always just one cause. But some of the causes of developing cancer could be it is an inherited gene from one or both parents. Now, this is not a lot of cancers. Like, if you look there, it's only 5 to 10% of cancers are from parents having a gene, spreading it to their kids. It's not a whole lot when you think about it. Now, it is a lot when you consider, oh, wow, there's millions of people that are affected by cancer. Absolutely, that's a lot. But ultimately, it's only 5 to 10%, which means that more than likely it's not genetic. Now, could genes affect your chances? Absolutely. But only about 20% of people, like 20% of people who have that gene or have a gene that could put you at risk for a cancer don't get it. So a lot of people could go throughout their entire lives having this cancer-causing gene that's never activated, which means they never develop cancer. Now, when they have kids, that gene may be passed to them as well. It's kind of a toss-up if your genes will be passed down in the way you think they will be, right? But you could spread that onto your kids and not even know. And could your kids develop cancer? Absolutely. So, as with genes are the Vegas slots of life, you never know what you're going to get. And unfortunately, there are some genes out there that put you at a higher risk for developing cancer. Now, more than likely, however, the gene has been at least activated or acquired during the course of living, epigenetic factors, due to carcinogen exposure and/or other gene mutations. They have here that carcinogenesis is likely multiple steps. You don't just breathe in, lead or something. I don't know, man. You don't just eat like processed food one time and then boom, cancer. Although, that might happen. I doubt it though. Gotta drink some more coffee. It's probably just, multiple steps. You maybe had some processed food, maybe you spent a lot of time out in the sun, or maybe, you also had a little bit of a gene process to it, and all these different things kind of cook together you have cancer. Now, sometimes really healthy people will develop cancer, and it was from, something you didn't even think about, right? I know, like, what, Red 40 or something can be a carcinogen, but honestly, most things are carcinogens. It's really hard to completely eradicate the chances of you coming into contact with that in, all those situations. Hold on. Let's see here. So, only certain cells are damaged. These gene flaws cannot be passed to children, and that is because it is an epigenetic process. Your genes didn't change, okay? You just had some sort of situation where, oh, I did this in my life, and so now maybe I have this problem, okay? Especially with like a skin cancer, like a melanoma, if you spent a lot of time outside, that doesn't guarantee your kids will have that, right? That was a problem that happened within your own body, kind of almost separately from your own, like, genetic disposition. So if you have a carcinogenic caused cancer, where something in your lifestyle or some event in your life caused that cancer to develop, that's not genetic per se. Now, could you have some genes that could contribute to that? Yeah, but you'd have to do genetic testing. If only certain cells are damaged, and that's what's causing the cancer, it's not a genetic thing, which means you can't pass it on to your kids, right? They're kind of a clean slate. So even though you got cancer, maybe let's say skin cancer, because that one makes a whole lot of sense, because you spent a lot of time outside and now you've got a little bit of melanoma. Your kids don't have that same issue because it's not like you got melanoma from your genetic sequence. Approximately 65% of new cancers are preventable. That's pretty good. If up to 90% of cancers are acquired, then 65% of those 90%, there was no genetic factor. It was just a carcinogenic process that just attacked your cells, and now your cells are causing problems. Which shows that, yes, carcinogenesis is multiple factors. Sometimes it's epigenetic, and sometimes it really is just factors in your lifestyle that cause your cells to kind of go haywire. This is the cell cycle. Now, with the cell cycle, there's a lot of different phases of it. They all go through the cell cycle, though. Every cell goes through the cell cycle. And this is where we see, this is how cancer cells are replicated. This is how any cell in your body is replicated, okay? There's different gaps and whatever. We don't have to go over it super in depth. If you want a redo of that, that's kind of an A and P sort of thing. But cancer cells go through the same process, okay? And in cell division, there's supposed to be a lot of different checks and balances, which in cancer can sometimes be skipped. But the point of knowing there is a cell cycle is that a lot of times our cancer medications are going to try and inhibit the cell cycle at certain spaces so that cancer can be either limited or tried to be exterminated, okay? We have here that you see the synthesis phase is highlighted because a lot of cancer treatment works well right there. When the DNA is replicated, okay, because you see here, the first growth phase is just normal, just the cell being a cell. Living, laughing, loving, using your energy, doing its thing. And then it goes in through this process of DNA replication, okay? And it's during that phase that basically the cell prepares to make another one of itself. Well, if we try and stop that synthesis phase, we try and stop that replication of DNA, the cell can't really duplicate, all right? It's not going to do anything because in order for a cell to be a cell, it requires a nucleus. And in order to have a nucleus with any sort of reason to exist, we need DNA. So, something to think about. Now, why does our body let cancer do its thing? Our body is really, really good at recognizing viruses, recognizing, bacteria. In fact, it's really, really good at recognizing foreign tissue from, transplants. To the point where we have to tell the immune system to chill out, okay? We need to, turn off our immune system almost in order for people to, live their lives with a new kidney. Why is that the case, that our immune system is so good at fighting everything else other than cancer? When it comes down to our cell's ability, or our body's ability to recognize self and non-self. Every single one of our cells has a marker, a tag, okay, that has our name on it, basically, okay? And constantly in our body, there are cells that kind of circle around and look and say, oh, is this us or them? And if it's us, perfect, you pass the test, you can keep on existing. If it's a them cell, then our body says, nope, we need to kill that. That needs to die right now. Our body is incredibly xenophobic. They do not want to see anything that doesn't have the me tag on it. Okay? Identifying self versus non-self. All right? Well, the issue, of course, that you can probably see with this is with cancer, all of those cells are our own. So those cells are dividing rapidly. They're doing whatever they want. They're not being useful to the body. They're using the body's resources and trying to spread around, causing trouble. And our body looks at that and goes, I don't know, man. They're citizens. What do you mean? We don't care. Oh, crazy. What do you mean they're citizens? Goodness. So yeah. Now, yeah. Now, this isn't always the case. Sometimes the foreign cells just they look so crazy, right? Sometimes the cancer cells look so crazy that they basically just appear to be foreign, right? Sometimes the antigens on the cancer cells can look foreign, causing the immune system to basically go, hey, that's not me, and then try and kill it. But there's a chance that it just looks exactly like the host cells, right? Sometimes that cancer looks exactly like the cell, or it appears to be exactly like the cell that it came from. So your body looks in and goes, that checks out. Yeah, you're fine. you keep on dividing. Look at you. You've been so productive. Which is really awkward. And if you have a type of cancer cell, or the cell has really grown and it looks like your cell, right? It's got problems, and even like from the naked eye, you could say that's not my cell, dude. But from from like a cell recognition standpoint, the cell looks at that cell and they have that human, your specific human like antigen on it. I can't remember exactly what it's called, but it's your tag, the tag that says me or them. And your body goes, yep, that's fine. Yeah, you keep on doing your thing. And you can imagine that this would be really, really hard to kind of fight because your immune system doesn't see it as a problem. And now, what are carcinogens? We talked about how carcinogen use is most of the time where people develop cancer from. And we have a list of them here. And you can see here that 30% of cancers are caused by tobacco use. You would assume that that's usually lung cancer because that's basically where the tobacco is going, but it can also cause bladder cancer because, and this is why, because all the waste products from the nicotine you've been bringing into your body needs to be excreted through somewhere, and it's excreted through the kidneys, and so the kidneys filter it, and it just sits in your bladder. So you are been smoking, I don't know, a pack a day for 7 years, and every time you pee, your bladder has been holding on to all that nasty pee, and that can cause cancer to kind of develop. So 30% of all cancers, tobacco use. Don't smoke. Anyway, excessive sun/UV exposure. Now this one's nearly 100% of all skin cancers are caused by just sun exposure. Being exposed to the nasty goober sun causes, almost 100% of skin cancers. Things to think about. Wear your sunscreen. Occupational exposure due to carcinogens. Now, this is only 4% of all cancers, but it's still something that really is an issue because this is a workplace thing, right? If, these people are trying to get money to help feed their families, and oops, now you have cancer. Really, really not great. You see a lot of this in asbestos and coal mining, and I don't know, if you're sitting on like an oil rig or something, anywhere where you're breathing in toxic fumes, that could do it. I know that's surprising, right? There's also environmental pollutants, kind of along the same lines, except that it's not your occupational. It's not an occupational hazard. It's just like a life hazard. So being exposed to factory smoke, wildfires, if you've got some sort of acid lake or something in your hometown, even being close to an area with like a really huge dump or something, I don't know. Anywhere where nasty stuff is being shot into the air and then breathed into you. There you go. And it's only 2%, but that's still 2% of, however many million. So, stinks. You can also get cancers as a kind of you can also get them from, viruses. Viruses work directly, and we talked about this a little bit with HIV and AIDS, but the way that viruses work are by hijacking your cell's ability to replicate. You can see why some of these viruses would be more likely to cause cancer, because our cells are already replicating viruses. They're already replicating in a wrong way, okay? There's a higher chance now for those cells or other cells to start replicating wrong, and now it's their own cell that's replicating wrong. Now, HIV We talked about Kaposi sarcoma as being kind of a hallmark sign of HIV. You know, those purple lesions kind of spread throughout the place. And that's cancer. That's an abnormal growth of like skin cells and stuff underneath that. Burkitt's lymphoma, I want to look at a picture of, but it's like a lymph node issue. It's a lymph node swelling. And so you'll see here these swollen glands. A rare aggressive type of non-Hodgkin lymphoma. Let's see. Exact cause is unknown, but it's thought to be associated with Epstein-Barr virus. Swollen lymph nodes, fever, night sweats, unexplained weight loss, abdominal pain, bone pain, and then you may also have some central nervous system involvement, including seizures and headaches. So, yeah, Burkitt's lymphoma does not play around. Ugh, man. It's got big, swollen lymph nodes. That's really sad. Shoot. So, yeah. Liver cancer with HBV, Hep B virus, hepatitis B, HPV, which I think is human papillomavirus. Yep, with oral, neck and head and cervical cancers. We do now have a HPV vaccine that came out kind of recently, and that's helped to reduce about 50% of the number of HPV cases, which will also affect how many people, get the HPV-associated oral, head and neck and cervical cancers. But, right now only about half of people are getting vaccinated for that. So, listen, HPV is not great. It stinks even if it doesn't, go into becoming cancer. Nobody wants HPV. Nobody wants those warts, especially genital warts. Nobody wants those. So get vaccinated, please. HTLV-1, it's a T-cell leukemia. T-cells we talked about are part of our immune system. Leukemia. And since those T-cells are part of your immune system, that leukemia causes looks like so it's a fast, so I guess there's a bunch of different types of it. Lymph nodes, bone pain, bruising easily, skin rashes. Characterized by out-of-control growth of mature T cells. That stinks. So, there you go. T-cell leukemia. Modifiable risk factors. Well, so if we can take those carcinogens we learned about and reduce our risk for having cancer from those by either being safe with those or not, I'm not going to tell you to not go outside, but you could just not smoke. That could help. 35% of all cancers, however, are caused by these three things, okay? Poor nutrition, so not having enough plant-based foods, fruits, vegetables, whole grains, in general, whole foods, or having a high red or processed meat intake, okay? If you've got a high red processed meat intake, you're not eating a whole lot of plant-based foods that have fiber in them. If you are not having a lot of fiber and you're just eating meat and processed foods, you're at a higher risk for developing cancer, especially colorectal cancer. Because if you're not cleaning out that colon, all that nasty stuff is just sitting in there, which can cause the cells to get irritated and start to grow out of control. Lack of exercise, obesity. Sometimes those go hand in hand, sometimes they don't. Losing weight in small increments can be less overwhelming. Just things to think about. Screening tests. Now, this is important to know. In cancer, in the context of cancer, if you are getting screened, you don't have symptoms. You're just simply like looking for signs. Okay, you don't have symptoms. You're like, oh well, maybe I could have, maybe I'll just check. I'm just checking. That's gonna be your self breast exams, or testicle exams where you're just kind of feeling around down there and making sure there's nothing new that's weird and wacky. Okay. You should do this on a regular basis, and the reason that you should do this is because you want to know what it's normally supposed to feel like. So if there's something new, you will know right away. Screening tests look for signs of a disease in people who have no symptoms. You're looking for signs, and you don't have any symptoms, okay? In the case of a diagnostic screening, however, this person has both signs and symptoms, okay? They have a sign and a symptom. So they come to you and they say, "Hey, I found a lump in my breast." Now we're not longer doing a screening test. We're doing a diagnostic test, because now we need to see what those cells look like, what this could possibly be, all that stuff. All right, the CAUTION acronym. Now, by the way, okay, is this CAUTION acronym perfect? No, it's not. I will be the first one to tell you that deciding to name this CAUTION and then having a lot of the first letters not be related to the things that come behind them is not super convenient. But it is really important, and it's a way of remembering things, and I don't really have the time to come up with a new acronym. If I come up with one, maybe I'll do an addendum. But for now, the acronyms for CAUTION are thus, okay? C, change in bowel or bladder habits. Maybe you're finding it more difficult to pee. Maybe you're constipated all the time, or maybe you have diarrhea when you used to just almost struggle with constipation. What's going on with that? A is a lesion that doesn't heal. So maybe you got a cut or something, and you've been trying to take care of it, you've done everything right, and it's still not healing. What is that? What do you mean? You've got some sort of cut in your mouth especially. Oh, I can't, it's just not going away. Unusual bleeding or discharge. That's often going to times like if you have been tracking your period and why am I getting my period right now? Why does my discharge look weird? Thickening or lump in the breast tissue or elsewhere. That's our T. For I would be indigestion or difficulty swallowing. That difficulty swallowing can come from a lot of different factors when it comes to cancer, but it could be due to a tumor growth or an enlarged lymph node. Indigestion, similarly. Obvious change in a wart or a mole. That's going to be more indicative of some sort of skin cancer or potentially, some sort of skin cancer. Nagging cough or persistent hoarseness. That's our CAUTION acronym. Let's go over it one more time. C for change of bowel or bladder habits. A for a lesion that doesn't heal. U for unusual bleeding or discharge. T for thickening of the breast tissue or anywhere else. I for indigestion or difficulty swallowing. O for obvious change in like a wart or a mole. And then N for nagging cough or persistent hoarseness. Here's an example of characteristics we look for when trying to see if something is melanoma or not. Just 4 little things, and it'll usually be, this is the changes to wart or mole we were talking about. So the mole started off like that, kind of symmetrical, but and now, it's changing. It's gotten much bigger. Look at that. Now, let's say for the sake of this that this is the same picture. It looks kind of similar. Some things we want to look for when it comes to melanoma. Does it have a 1/4 inch diameter or greater? Is it a strange color, maybe darker than you would expect it to be? Maybe darker, redder, purpler, I don't know. It's a weird color, not just brown. The border is irregular, so instead of being, a nice little circle or something, it's now this weird kind of amalgamation. And you'll see that with all of these. The border is not like you couldn't do that without, making little fine adjustments. This right here is where the mole started, okay? You'll see that that's a very nice border, okay? And now where we're at here, the border is not regular at all. You'll also see asymmetry. You'll see asymmetry. I think there's a little less asymmetry with that one right there. There's asymmetry with that one. There's asymmetry with that one. And asymmetry with this one. You can't really... Now, the mole used to be symmetrical. Cut that right down the middle. But right now, you can tell that everything looks off. Proportions are different. We'll skip the questions for now. They have screening guidelines. Just... We talked about in class, if you get your first mammogram at 40. If you don't have any genetic risk, take it at 35. If you do have a genetic risk, colonoscopy at 50. If you have a genetic risk, you're going to have a colonoscopy every 3 years after that. I think if you don't have a genetic risk, it's every 5 years or something. Just because they want to check, they want to screen. Even if and they are screening because they want to check if you don't have any symptoms. They want to screen. They want to screen before it becomes diagnostic. Cancer is scary. Patients fear dying. They fear pain. They fear disfigurement that results from cancer treatments, losing hair, potentially getting big chunks of your skin pulled out. Those are scary things for people. Loss of relationships or jobs. Will my spouse want to stay with me now that I have cancer? Nausea or vomiting. That's a hard way to live. You can't, you're constantly fighting against your body's desire to just not want to eat anything. And you need to eat things. People will want you to eat things, and it's not comfortable. Hair loss, not cool. So people are scared of cancer, and it is a scary process. But the first part of the process of, okay, well, now let's say this person has cancer. What do we need to know about the cancer, okay? What type of tissue is the primary type of tissue? And that will determine what kind of cancer this person has. Now, we're just a nurse, and this is really just talking about the pathophysiology of things so that we can understand what's kind of going on with this patient. We'll talk about the nursing implications kind of later, but right now, I want to know about what cancer is, okay? Now, there are 3 types of things we're going to talk about here, and that right now we're learning about which type of cancer, or which type of cell, where the cell that the cancer was started at came from, okay? Carcinoma are glandular or epithelial tissues, okay? Like your, lymph nodes, epithelial, so your skin tissue. Sarcoma comes from connective tissue, joints, that stringy connective tissue that comes between all your organs, all that stuff. Those are sarcomas. And then hematopoietic, cancers come from bone marrow. Because bone marrow is the thing that creates your blood cells, okay? Your red blood cells are created in your bone marrow. So we call hematopoietic cancerous growths that because they're going to be affecting your blood, some sort of aspect of your blood, because they come from the bone marrow. A person must have a biopsy or surgical specimen to examine under the microscope. You're not going to just be making this stuff up. A doctor's not going to be like, I think you have this, and the patient just came to the ER 2 minutes ago. They have to put an actual form of the person's tissue via biopsy or whatever under a microscope and see what kind of cell the cancer has started from. Okay? Now from there, you're going to grade the cancer cells and cancer cells and see maybe what has started causing them, what they're receptive to, what makes those cancer cells tick. Okay? Now, when it comes to grading them, all right, we have 4 grades of cancer cells that we can have. All right? Now, these are all bad in different ways. It just happens to be that some of them are more bad quicklier than others. Okay? Grade 1 cancer cells are well differentiated, meaning they look pretty quick. They look almost the same as the normal cells. They are kind of low grade cells. They act mostly normal because they look really similar to your normal cells. Now they might be, a little bit faster as far as their replication is concerned, but overall they are slow growing. All right? So these cancers are more insidious. Grade 1 growths are more insidious. They kind of stay under the radar a little bit. Grade 2 are moderately well differentiated. They look a little bit different than those cells. And you can tell there's a difference, but not a huge difference. And they're starting to lose those normal features. You're able to say, oh, that's definitely, I don't know how to put my finger on it, but that's not the cell that I was expecting to see at that point. Grade 3 are poorly differentiated. We're getting to the point now where we can definitely tell that that's not supposed to be there. It looks pretty bizarre, and it's now having trouble doing its normal functions, okay? Because the cells, the way that they are in your body right now in a non-cancerous specimen, they are meant to do a thing, and they are engineered because of their, genetic sequence to do one thing really well. An epithelial cell is meant to be part of a group of epithelial cells and communicate with those epithelial cells and hold together some sort of structure, okay? Well, now, if we've got some sort of poorly differentiated cell, it wants to do its own thing, it's not going to be able to do what it wants to do, or what it's supposed to do as well, okay? And grade 4 is going to be the extreme of this list. It looks absolutely different. It's almost hard to tell what the original cell was at this point, and it can't function at all in the way that it's supposed to. In fact, it might not even be able to function, period. It's just a waste of space. Yeah. Now, you would think, but remember, all the grade 4, it is a high grade deal. It is fast growing, okay? So the higher grade you get, the faster growing you are, okay? But also, the higher grade you get, the more dangerous you are, okay? Because grade 1, you still can do your normal functions, all right? It's almost hard to tell that it's cancerous. Grade 4, it's absolutely cancerous, and it's getting cancerous. It's going to get to be a problem real quick, okay? Now, you would guess that any cancer treatments that are based on rapid proliferation would do really well with grade 4 cancer cells and not as well with grade 1 cancer cells because they're slower growing. A lot of times, those treatments that are based on, you're replicating. If you're not replicating super quickly, it's not going to be as effective as a cell that's replicating really, really quick. So, there you go. Tumor markers. Any protein that might be increased in the presence of rapid growth, as in cancer. Okay? Now, this is the question of what makes those cancer cells tick. Okay? What makes them want to do what they want to do. All right? Now, there are certain enzymes that your body might produce that might kick that cell off into wanting to produce a lot of itself. Metabolic products. If I put enzymes into the search bar, it's going to pop up a bunch of letters and numbers in a lot of sequences that I don't know. So I don't think that would be a useful thing to search up, but I will be searching up metabolic products, tumor markers. Cancer cells often exhibit altered metabolism, leading to changes in the levels of certain metabolites in body fluids or tissues, which can be detected or used for diagnosis, prognosis, and monitoring cancer progression. So some examples of metabolic markers being lactate. Elevated lactate levels are a hallmark of the Warburg effect and be a marker for certain cancers. Amino acids, changes in the metabolism of amino acids, like glutamine, can be associated with cancer. Glutamine again. Well. Lipids, altered lipid metabolism. So glutamine, yeah, sorry guys. Sorry MSG lovers. Glutamine can cause cancer. It is a carcinogen. Lipids, altered lipid metabolism, including changes in carnitines, are sphingolipids, can be used for biomarkers for certain cancers. And then other metabolites such as fumarate, malate, and pyruvate have also been shown to be altered in cancer. Metabolic products, yippee, and then so problems with the way that your body metabolizes things could cause cancer to be more prolific. And hormones, the big one example here is estrogen in breast cancer. You have a higher estrogen count in that area, which causes those cells to kind of go crazy, and now we have breast cancer. Oh goodness. Growth markers, I think those will also be long things that I don't have any sort of concept for. Yeah, look at that. VEGF, HER2, HGF. So, but those are growth factors that can cause the proliferation of abnormal cells. And then antigens. Tumor markers, which are substances produced by cancer cells or the body in response to cancer, can be used to monitor the effectiveness of cancer treatment. Blah, blah, blah. So, tumor markers like prostate-specific antigen, cancer antigen 125, and carcinoembryonic antigen for colorectal cancer, alpha phenoprotein for testicular cancer. So you can look at all of these different antigens to determine the risk of that person for getting that cancer and / or like how bad it already is. So things like that. Now, being able to measure these things, measure the tumor markers, can indicate not only what kind of treatment this person should be getting, but also how effective the treatment this person has been getting has been. So, in general, if all of these things go down, that's good. If we see a decrease in estrogen, we like that for somebody with breast cancer. If we see a decrease in prostate-specific antigen, we like that. That means that what we've been doing has been working. Now, if we see an increase, we have excessive amounts of those growth factors or those hormones, now we have a problem. Now we say, okay, well, whatever we're doing isn't working, it's getting worse, okay? Another thing that could cause these problems would be excessive receptor sites. The excessive amounts of stimulating factors are definitely a yes, but if we have both, a lot of stimulating factors or even an increased amount of them, and we have a lot of receptor sites for these specific things, then those things are going to be flagged all the time because we have more receptor sites that can just be filled with them, right? So those can help to increase the cancer growth, and we don't want that. Knowing where the excess is can help determine the different methods of treatment. Okay. So those are the three things that you're going to be looking for, just what kind of cancer it is, what kind of makes it tick, where did it come from. Now, in a broader scale, when somebody says, oh, I have stage 2 cancer, insert type of cancer here, there's a reason that they do stages for this. They grade a lot of things with cancer, and we need to know both the grades, the stages, types, blah, 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 okay? This is very general. Stage 1. If you have stage 1 cancer, that means you have a tumor, a small tumor, maybe 1 or 2 small tumors, no lymph nodes that are affected, and no metastasis, okay? Grade 1, you have a little tumor, and no lymph nodes are involved, no metastasis has happened. That is just a very, singular point of cancer. Stage 2. You may have a larger tumor. You may have 2 or 3 tumors, okay? You may have a node. You may have 1 lymph node that's kind of involved. You may. It's not necessarily. It kind of depends on the size of the tumor. If the tumor is pretty big, maybe there's 2 of them, and you maybe have a lymph node, or maybe you don't have a lymph node, it's just a big tumor, then we're talking about stage 2, okay? There's still no metastasis in stage 2. Stage 3, now you've got more tumors, okay? You've got 1, 2, 3, maybe 4 tumors, okay? You definitely have a lymph node involved. In stage 3, there's no if you have a lymph node, it is you have a lymph node, maybe 2 lymph nodes that now have gotten signs of that cancer spreading, okay? But in stage 3, there's still no metastasis. Still no metastasis for stage 3. Stage 4, you have any number of tumors infected, any number of lymph nodes infected, and now you also have metastasis. So I have a cute little picture here. Stage 1, 1 little tumor. Stage 2, 1 big tumor and a couple little tumors. Stage 3, these are lymph nodes, okay? I don't know why they have that. I don't think they should have that, but whatever. And now, stage 4, you've seen growth affecting more areas of the lung. We have a couple of things to know here, just little pieces of vocab. Sentinel node, that's going to be the first lymph node. They call it the sentinel because it's like a guardian node. when people do tests, like when you do diagnostic tests to see how far the cancer is spread, if that first lymph node in line of that cancerous area doesn't show signs of cancerous growth, that means that lymph node, that all the lymph nodes after it haven't been affected, because the products that tumor or that cancer is secreting have to get through that lymph node in order to affect the other ones. So if that first lymph node doesn't show any signs of cancer, then that person doesn't have any cancerous growth in the other lymph nodes, which means they're at a stage 1 or stage 2 cancerous growth thing. Tumor burden is the number of tumors a person has. Obviously, if you have a high tumor burden, you have a lot of tumors. If you have a low tumor burden, you don't have a lot of tumors. Things to think about. So metastasis only happens in stage 4, and stage 4 cancer is kind of that's the big scary one. You know, people will say, oh, I have stage 1 cancer, well, maybe I can do something about it, but stage 4, they know that's the last one. Metastasis is specifically characterized by the spread of the original cancer to one or more distant sites, okay? So from where it started, the cancer has now spread. Okay? Now we call it a different name. Now instead of breast cancer, it's metastatic breast cancer. Okay? Instead of lung cancer, it's metastatic lung cancer. Whatever. Okay? Now the reason that they call it metastatic breast cancer instead of breast cancer and liver cancer, let's say, is because only one cell is still cancerous, by the way. Now let me repeat that. Breast cells are the ones that were starting the problem. They started growing weird, okay? The cells in the breast started growing weird, and now the cells of the breast have traveled somewhere else. Has the type of cell changed? No. That breast cell that started in the breast and has now worked its way all the way to the liver has not become a liver cell. It is a breast cell that has infected the liver cells. So, that is why if we have a cell that started in the breast cancer, or started as breast cancer, and then it's traveled somewhere else, we just call it metastatic breast cancer. We're not going to call it metastatic breast cancer with liver cancer. That's wrong, because it's not a liver cancer. The cells in the liver are growing just fine. They're now just being encroached upon by these breast cancer cells. Anyway, just things to know. If they biopsy the cell and the cells in the liver look kind of like breast cancer cells, then we can figure out it likely started in the breast, obviously. All right, 2 different types of breast cancer. Here on the right we have ductal cancer. It's in a duct. And lobular cancer is below here. It's more diffuse. You can see it's more spread out. Ductal cancer is more in one place, so you could tell that, but either way, they're going to want to probably cut this guy off. If they can't defeat it, they'll probably slice it. But we'll talk about that in a minute. Let's talk about safety ABCs. Lung cancer is going to be the one that's going to be put your patient at risk for dying the fastest, simply because airway, breathing, circulation. Not being able to breathe is going to kill you faster than not being able to metabolize things. Metabolism takes the whole process of metabolism takes a lot longer than the process of your body to compensate when it comes to breathing. So we see here, we have all of these growths in these lungs. All of them right here. That decreases the amount of viable lung tissue that this person has to breathe from significantly, which kind of sucks. That's not good. So this is going to be putting our patient at a huge risk for gas exchange issues. There we go. Gas exchange problem. We are already at a very high priority. There's a case study that I really am not interested in looking for. But I will talk about some things to know when it comes to patient care. Now, sores in the mouth. Patients who have cancer will usually be undergoing some type of chemical radiation, chemotherapy. Okay, this specific type of or it's not chemical radiation, it's just chemicals. They're shooting chemicals into this person that are going to help to destroy rapidly producing cells. Rapidly producing cells. And these are not like, oh, well, we'll only destroy rapidly producing cancer cells. There's no differentiation. The chemotherapy will try and shut down any rapidly proliferating cell that it sees. All right? Now, the problem with that, of course, is that there are some cells in our body that naturally have to replicate a lot. Our skin replicates all the time. Any mucous, the membranes in our mouth have to replicate a lot. And so if you have any sort of cut, lesion, anything like that in your mouth, the chances are that it's going to take a lot longer for those sores to heal. And that can be very painful. So chemotherapy can cause sores in your mouth, and because it causes that hair fallout, doesn't cause a lot of hair to grow because hair is also rapidly producing. Blood cells going to be decreased because those want to be rapidly produced. They can't be as well. So, boom, you're going to have complications that maybe look like anemia, and you will have a lot of problems. Nursing interventions for somebody with these mouth sores, non-alcoholic mouthwash, please, this is not the time for Listerine. That's going to burn real bad. There's also this thing called magic mouthwash, which will help to also numb the areas, which could help the patient eat things better, because, yeah, those sores hurt real bad. Don't use lemon glycerin swabs. That will hurt. It just don't cause the patient any undue pain. They need to be comfortable. Provide good oral care, even if they have dentures. Take them out. Use a soft bristle toothbrush. Take care of them. We don't want any sort of thrush growth. We want them to be comfortable. Yes. Things to know. Each chemotherapy side effect with the correct intervention. Anemia. They don't have a whole lot of blood, so administering epoetin alpha, if it's prescribed, of course, but if they need that, epoetin alpha will help to stimulate red blood cell production, which can help with the anemia, of course. And, obviously an iron supplement wouldn't be a bad thing if they can metabolize it properly, maybe with also a vitamin C agent there to help turn that iron 3 into iron 2 to improve the absorption. Neutropenia, neutropenic precautions, avoid fresh fruit, keep them away from big crowds. Maybe if they want to wear a mask, advise that. Washing hands really, really well. Inspect for signs of infection. Thrombocytopenia, it's going to be a reduced amount of platelets, putting this person at risk for bleeding. So, avoiding IM injections, venipunctures, for sure. That's going to be a big one. For neutropenia, there's also another thing we can do. I want to look this up because it's important. Don't. Okay, well, it's not there. It's up here, I'm sure. Hello? Okay. For leukopenia, you can give them Neulasta, and that can help to stimulate the production of white blood cells. Of course, it all comes down to prescription, but those are things you can talk to the provider about. Patient factors, physical functioning, performance status. Okay, so how able are they to get up, move around? What other comorbid diseases do they have? Have they had diabetes their whole life and now they have bladder cancer or something? I don't know. I don't make the rules. What other problems do they have? And how will the cancer treatment affect those issues? Organ function and status and physical exam. If their liver is failing and now they have breast cancer, we've got a huge issue. Concurrent medications, what other medications are they taking? Do those interact with the cancer medications? If so, what does that look like for their treatment? And then the goal of therapy. And then we'll talk about the goals of therapy because when it comes to cancer, people want a cure. Okay, people will desperately want a cure. But sometimes you can't Cure is a quick thing, and no doctor will say cure because that could put them at a legal. They don't want legal ramifications of saying your cancer is cured, and if it comes back, that can be debilitating for people. What they'll say is that they don't want to see any evidence of disease. In a cure case scenario, they're going in and they're saying this treatment will completely get rid of it to the point where we will not be able to see it anymore. Okay? You don't see any evidence that it's here still. That's a cure treatment. Those are things that work. People like fast results. Cure treatment will get them the faster result. Okay? People like that. People like hearing cure. But that's not always the thing that can be done when it comes to cancer. Control effects try and stop the cancer from growing. If you know you can't cure this cancer, you'll say, well, at least we can stop it from getting worse. Let's say we have a grade 2 cancer where, the cells are not functioning as well as they could. We don't want it to get worse, okay? So let's just try and limit it to this one area. Keep it under control. Keep beating it down so it can't get worse. Less satisfying, but at the same time, at least you're trying to keep that cancer from getting worse. And of course, palliation. The goal of treatment here is to keep the patient comfortable. Very likely their prognosis is not great if they're looking for palliation treatment as a goal of therapy. At the end of the day, though, it's very important. We want to make sure that the amount of life that this person has left is not lived in pain and suffering. We want to keep this patient as comfortable as possible to help with the transition. And then also, what kind of treatment is this person getting? Is it local treatment? Now, local treatment are going to be the surgeries where you're cutting out a big chunk, the CHOP method, radiation therapy, burn method, where they literally just zap that area of your body with a bunch of radiation and hope that stops the cancer from being able to get worse. Kill all those cells, hopefully kill the problem cells, and then move on. Special techniques like cryotherapy and laser therapy, same idea as burn. Those are going to be, one of those is freeze and one of those is zap, I guess. But those are your ways of dealing with local treatment. Regional treatment comes down to our chemotherapy idea, the systemic treatment of cancer. And that will be for when the cancer has metastasized or is close to doing that or whatever. Obviously, local treatment helps, but if the cancer is already spread throughout the body, local treatment is only going to cut away a chip of the iceberg. Systemic treatment for cancer goes throughout the body via the bloodstream and is good for widespread disease and for cancers with a high risk of reoccurrence. These are going to be your chemotherapy, biotherapy. By the way, what the crap is biotherapy? That's type of cancer treatment that uses the body's own immune system to fight cancer cells. Hey, well, that would be nice. Involves administering substances or cells that can stimulate or enhance the immune system's ability to recognize and destroy cancer cells. Not effective for all types of cancer, can have serious side effects such as immune reactions, of course, because your immune system would kill you if it could. May require multiple treatments or combinations with other therapy, but can target cancer cells specifically, may have fewer side effects than traditional chemotherapy because it just focuses on the cancer cells, and can potentially boost the immune system to fight future cancers. But, of course, if your immune system goes too crazy, we don't want the immune system to, kill you, because it will. It would. Your immune system is not your friend, it is your unwilling participant. Well, yeah. Hormone therapy as well. Oh, targeted therapy. Oh, what the crap. I figure it's similar. Type of cancer treatment that uses drugs to precisely target and attack specific cancer cells. So, in biotherapy, it's just cancer cells that your body is meant to, look for. Targeted therapy is kill these specific cells. Hormone therapy, stop this hormone. And then here's more hormone therapy here. Common hormones to be tested for. HER2, that's I think that's a hormone for protein on the surface of cells, and breast cancer. Cool. Triple negative. So these are all, so this is estrogen receptors, progesterone. Okay. Yes. Heck yeah. So if you have a problem with any of these three hormones here, they can just say, oh, well, let's just stop this hormone then. Great. Unfortunately, there are such breast cancers as triple negative. And just like triple threats, they are not great. I don't know, I'm just making that up. Unfortunately, the hormone therapy for each of these will not work with triple negative breast cancer because it's not working. That's not what's causing the breast cancer in triple negative breast cancer. But for estrogen receptor stuff, we have estrogen blocker, temafaxin for pre and postmenopausal women, and then aromatase inhibitors for postmenopausal women to help with the estrogens. And then, but for triple negative breast cancer, all they can do is try and suppress the immune system. Hold on. How do immune checkpoint inhibitors work for TNBC? Blocking proteins that prevent the immune system from attacking cancer cells, thus allowing the immune system to recognize and destroy tumor cells. Oh, so at those checkpoints where usually they would say, oh no, this cell is a citizen, you just say, hey, immune system, you can kill him. I like the idea that your immune system is just a bunch of serial murderers that have just been kind of placated with arbitrary rules. That's really funny. No hormones will work for this cancer. Of course, because it's triple negative. There's all the hormones that would cause it are not causing it, so boom. Alright, cancer treatment mechanisms in action. Targeted therapies inhibit cell signal pathways to inhibit synthesis. The monoclonal antibodies block and modify receptors on cell surfaces to help the immune system recognize and destroy tumor cells. And then cytotoxic therapies just damage the DNA. They just bring a big bazooka to the party. Hey, it works sometimes. Unfortunately, radiation therapy and chemotherapy are cytotoxic, which means they kill your cells, which is the point, but also sucks. But if you've got both of these, you hit the cell at multiple stages, right? Here at radiation therapy, it hits you at the G2 or M phases when the cell is preparing for mitosis to damage the DNA that way. Chemotherapy attacks the cell during the synthesis phase when the new DNA is formed. So, yeah. So when the actual cell is separating, radiation therapy destroys it or tries to destroy it. Chemotherapy just stops the DNA from being formed. If you've got both of these, good news. Those cells will probably not be able to be formed. Yay, cancer is down. Unfortunately, that affects all the cells in the area. Radiation therapy is going to be a big box on you that looks real nasty, like the worst sunburn you've ever gotten. And chemotherapy goes through your entire body. So yes, maybe the cancer cells have been stopped/killed, but that's going to hurt a lot of other cells in your body. Immune checkpoint inhibitors block proteins that limit T-cell action. Like I said, the T-cells are going to go in and they're going to say, so you mean I can kill all these people? Yes, absolutely. Given IV, often an inflammatory response to immune-mediated activity with 90% of patients. Because the body's immune system now no longer is in check. You say yes, kill everything. And the immune system says, okay. So you may have frequently watery stools because now you have inflammation in your colon. You may have inflammation in your lungs. That's not great, with more common with combination therapy. So if you have immunotherapy and some sort of radiation therapy, I guess. Dermatologic pruritus, rash, dermatitis, erythema, photosynthesivity, because your cells on your skin are really, they're inflamed. They are constantly being, I guess, hazed by the T cells that are running around doing whatever they want, so that can cause a lot of problems. Toxic epidermal necrolysis. That's not good. We don't like that. So yeah, not good. And then endocrine toxicities with hypophysitis, which is pituitary inflammation, thyroiditis, thyroid inflammation, and adrenal insufficiency, diabetes. So, immunotherapy is not great, but it could work, maybe. You'll notice all of our immune checkpoint inhibitors for immunotherapy are MAB. MAB, 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 MAB. Those are our mouse little buddies. Problem with MAB, kidney problem. Kidneys are being slam pasted with these, so keep that up to mind. Immuno checkpoint inhibitor complications can occur up to 3 months after treatment. And we have more grades. We have more grades to use for this one. Stick with me, okay? We're at 42 of 59. Immuno checkpoint inhibitor complications, they can either, they can last for a long time, all right? And they come in different grades. So because your immune system is kind of let off its leash, you can have up to 4 grades of issues. Grade 1 being, you can live with it. Grade 4 being, you will die if you don't seek medical attention immediately. Alright, grade 1. Life kind of sucks. Maybe you've got some runny stools and you feel tired, but you can still do your ADLs. You continue the drug, you manage the symptoms, eat some bananas, have some Pepto-Bismol or something, and move on with your day. Grade 2 is moderate. ADLs do show limitations. Maybe it's harder for you to go up the stairs. Walking around all day and work, or just even sitting in a chair all day and trying to keep your back straight really is just tiring. You maybe feel, it's hard for you to keep your blood pressure under control. Grade 3, severe. ADL effects are disabling, okay? Now you're maybe unable to get out of bed. That's a big one. At that point, during grade 3 of an ICI complication, you will stop the drug. The doctor will stop the drug and give you some steroids to help to kind of suppress that immune system. Say, hey, chill out. It's time for you to chill. Stop. And after that, they're probably going to try it again. What they don't want to see is grade 3 ICI complications becoming grade 4 ICI complications. Grade 4 ICI complications are life-threatening. These are issues that could kill you, such as neurologic toxicity. Yay! Altered mental status point. So you're going to be getting that bad headache, fever, and then seizures, coma death. Yay! And of course, you're going to want to hold the drug will be held and the steroid therapy will be figured out. However, that at that point, the problem is now trying to make sure this person doesn't die from the complications. They can also have hematologic toxicity with crazy neutropenia. Look at that. Neutrophils less than 1,500 per microliter. You guys, that's crazy. Thrombocytopenia, platelets less than 75,000. This person, if they even look at a razor, they're bleeding. Okay? Don't even. That is crazy. This person may also have encephalitis, inflammation. Oh my goodness. Brain swelling. Oh gracious. Myocarditis, inflammation of the heart tissue, renal failure, respiratory distress. Oh, by the way, this is because your immune system is like, yeah, let's just kill everything. How about we destroy everything? Maybe that will get the cancer to leave. General complication. Okay, so they left out the general side effects of cancer treatment here, which is silly. But we're going to talk about the general side effects right now before we go on to general complications. General side effects of cancer treatment. Alopecia, losing your hair. Okay? Now, people will say you can give them pegfilgrastim, but most of the time people are just going to lose their hair. You can try the cold compress stuff. Otherwise, it's just coping and, making sure that they cover their head and whatever to keep it away from direct sunlight and all that stuff. Taste changes. Red meat might taste terrible, but also, I don't know, cake could taste terrible. I don't make the rules. It's kind of different for every person. Mouth sores, we already talked about that. Nausea, they might be given Sofran or Kytril for that. Probably spelled that wrong. Vomiting. Bone marrow suppression, because they overall are suppressing rapidly dividing cells, which may cause anemia, which we already talked about. You can give alpha epoetin for that. Thrombocytopenia, those low platelets. which there is another thing that can help to make make platelets, but they don't have it written down here. And then leukopenia for Neulasta, or Neulasta for leukopenia. Peripheral neuropathy, ice on feet and hands during IV installation of Taxol derivatives to help just keep that pins and needle tingling down. Hormone therapy probably won't manifest any of those if you're getting like estrogen receptor blockers or something, but the person might also get hot flashes, gynecomastia. Yeah. General complications. Now, complications are not good. The side effects kind of stink and they're not fun to live with, but you'd rather have a side effect than a complication. Complications for cancer would be sepsis or DIC. Oh my word. And this is gonna likely happen during nadir. I don't know why the crap they call it nadir, but nadir is the lowest point of cell count. That's the lowest point when you have the lowest amount of white blood cells, lowest amount of red blood cells, and it usually happens, after a couple or triple or quadruple amounts or rounds of chemo, and cell production basically has been halted. Kind of stinks. You can also have a spinal cord compression, but this isn't necessarily due to the tumor, it's not necessarily due to the treatment. It's more due to the tumor growth, like if the tumor is pressing on your spinal cord. So still a really bad thing. We don't want this person to be paralyzed and have cancer. That's like a double whammy, but it is something to consider. Hypercalcemia. Why is that? Okay, so if cancer is metabolizing to our bones, the reason that our bones are constantly building and breaking themselves up is because our bones are also a resource for our body for calcium. If we ever need any more calcium, because calcium is really important as far as like muscle action is concerned. So if we ever need more calcium, our body will just be like, okay, osteoclast, how about you just bite down on our bones and we can just release some calcium into the bloodstream, right? From bone metastasis, and I want to look up exactly why, but I think it has to do with the fact that those extra cells cause an increase of, hey, well, we should probably destroy that. We don't want that bone metastasis, and we need to destroy these cells in the bone, which unfortunately gets rid of some of the bone, which causes more calcium to be released in the bloodstream. But I don't know that, so I'm typing it into the Google search bar. Hypercalcemia in bone metastasis. Because the cancer cells stimulate bone resorption, causing calcium, shooting calcium into the bloodstream, and potentially due to tumor-derived factors like parathyroid hormone-related protein. When cancer spreads to bones, it can cause a breakdown of bone tissue, leading to the release of calcium. Well. Tumor cells in the bone produce factors that activate osteoclasts, there we go, which are cells responsible for bone reabsorption. This increased bone reabsorption leads to a higher concentration of calcium in the blood, and also this cancer cells producing that, which mimics the effects of parathyroid hormone, which causes calcium levels in the blood to release by stimulating bone resorption and reducing calcium excretion by the kidneys. Well, it's just so interesting. Anyway, superior vena cava syndrome, which we have slides for, so we'll just go down. Oh, this is nadir. By the way, during nadir, you're not going to be giving chemo because you do not want to make this worse, obviously. Moving on. Okay, superior vena cava syndrome. So you see this right here? That's our superior vena cava, okay? It's the thing that helps to bring back blood from the brain and the top parts of our body to our right atrium so that our heart can send it to our lungs and be reoxygenated, whatever, okay? Well, so let's just say we have this massive freaking tumor here pressing on that really important vessel, messing up the pressure system. The reason here that our blood even wants to come back to here is because the pressure here is less. All right, the reason blood wants to move, right, is because the pressure here is less than the pressure here. So the blood says, oh, well, we'll just move through here. Oh. And then eventually the pressure here will become more than the pressure here. So the blood will say, well, we don't like pressure, so we're going to move into the right atrium and then be moved around and blah, blah, blah. Okay? Well, this whole perfect system of pressure movement kind of gets messed up when this pressure, or when this tumor is pressing on the superior vena cava. Really awkward, because now there's a lot of pressure here. Don't matter that the pressure is like lower here. The pressure here is super high, or at least high enough that the blood here that's trying to come back says, I'm not freaking going back. Are you joking me? And so some blood might trickle in, but otherwise most of the blood is kind of building up back here, which is not good. We don't like that, actually. Causes a backup of blood traveling back to the heart from the upper part of the body, which will cause facial and upper extremity edema as all of the extra fluid from these tissues kind of swells back into or from the blood vessels swells back into the tissues because it really doesn't have anywhere else to go. Shortness of breath, headache, chest pain, facial plethora, distended neck and chest veins. And you know, that buildup of pressure probably is not great for the brain tissues, and I'm sure that it could cause some sort of hemorrhage, and we don't like that. Next, tumor lysis syndrome. Okay, tumor lysis syndrome is not good. Tumor lysis syndrome is an acute issue. That's good. But it will happen in the first 3 to 7 days after the first treatment of cancer. Well, so tumor lysis syndrome is essentially, let's just break it down to the simplest things, okay? In tumor lysis syndrome, whatever you did to help cause the breakdown of that cancer tumor worked real well. In fact, it worked so well that there's so much waste product accumulation in your body because that tumor has been absolutely annihilated that causes your body to freak out and almost go into shock because there's so much crap sitting around in your body. So we will have hyperuricemia, lots of uric acid because our cell was being destroyed, hyperkalemia because potassium is the primary intracellular electrolyte, and all those cells that just got blasted will now be releasing their potassium into the bloodstream. Hey guys, high potassium? Sounds like a dysrhythmia to me. Hyperphosphatemia. Now this is less common in spontaneous tumor lysis syndrome, but this is, I mean, if they're reusing phosphate, but if you have hyperphosphatemia, you may also get hypocalcemia, because as one goes up, the other goes down due to them keeping each other in check. But if there's too much of one, it'll cause too less of the other. Long story short, metabolic acidosis, because we have all of these acidic waste products, often associated with a secondary acute kidney infection. I wonder why. All of that stuff flowing through the kidneys, causing the kidneys to freak out, and other end organ dysfunction, such as seizures and arrhythmias, because the brain does not like all this crap being flooded through it. Arrhythmias, hyperkalemia, stop the heart entirely. If you're lucky, you'll go into a dysrhythmia with hyperkalemia. That's crazy. Anyway, usually after the first treatment, but not after that, though. So this is a one and done kind of thing, hopefully. You don't want it twice. That sounds awful. Oh, extroversion. Okay, so this is definitely a problem, and this is a bad cancer treatment thing. If you are inserting chemo into a vein, this is really important. If at any point cancer chemotherapy treatment is being inserted into a vein, this is why they prefer central lines. If it's ever being inserted into a vein and that person goes, hey, that burns, stop immediately. Stop immediately, give an antidote, disconnect the thing. Do not mess around with that. Because if it ever starts burning, that means that whatever is in there, that chemo cancer treatment is going into the actual tissue. Now, like I said, chemo treatment does not differentiate. It will kill whatever it comes across. And guess what? All of these cells that used to be, they are rapidly dividing. Those are skin cells. Okay? So the cancer treatment is going to say it's time to get to work, and it is going to cause tissue death like you've never seen. Well, I guess like if you have seen. How do we stop? We want to prevent this. Okay? We don't want this. Ports help because we know that it's going directly into the vein, but if it happens to be here, things to know. If it starts burning, stop the infusion and still an antidote into the surrounding tissue and disconnect. We do not want this vein. We don't want this. This is terrible. This is awful and terrible. We don't want this. It is awful. Do you want this? Didn't think so. Anyway, the drugs that are most likely to cause this specific complication are anthracyclines, such as doxorubicin. But, yeah. So, question, blah, blah, blah. Okay, and then this is questions about radiation. Okay, this has been a long recording. We are almost done, okay? We are so close. Radiation is an external beam of very, very fast-moving particles that are not great. When you shoot somebody with this, it is they quickly destroy that tissue. They quickly sap the tissue, burn it. They're trying to make it die, basically. In general, person undergoing radiation therapy for cancer is going to be tired, weak, and they may not even be hungry. They may experience shortness of breath, cough, and difficulty breathing, and that's especially if where their cancer is being irradiated is like close to the lung tissue. The skin around the area will be reddened or darkened, like really bad sunburn, blistering, dry, itchy, might also be peeling. It's like the worst sunburn you've ever seen. But here's what is important as far as nursing care is concerned. Do not ever put anything that the doctor has not prescribed on there. I have this lotion from home. No, don't even think about it. Because imagine you freaking put a little bit of an oil-based lotion on that place, and now that person is going in for radiation therapy. Brother, you just put freaking... you just helped to get... that's so... Oh my goodness. Yeah, you just put, I don't know, what's the freaking word? I'm trying to think of it. I know exactly what it's supposed to be called. Napalm. Yeah! Now, is it bad in napalm? No, but I'm gonna say it is because it works, okay? You just put napalm all over that person's area, and now you're about to blast it with, like, this crazy that's terrible. It's gonna cause that area to just get totally screwed up. So no skin oils, no lotion. If it needs to be washed, use with mild soap and water, pat dry. Don't try and wash the box mark that they put on, because that is the box that is supposed to help the person who's administering the radiation know exactly where to put it. Don't wash it off. Don't do that. For their throat, if they're experiencing radiation, they may have a sore throat. If it's close to the esophagus, they may have difficulty swallowing, because their salivary glands can be destroyed by radiation, which might cause them to have dry mouth. So maybe they can suck on some ice chips or something. Other chest discomfort or pain, the loss of neck and chest hair, shoulder stiffness, and yeah, the side effects, like I said, these side effects are kind of dependent on where the radiation is. Like, if it's like a radiation on like the top of your thigh, you're gonna have like weakness in that leg and pain in that leg and the skin problems, but you probably won't have the respiratory issues or the dry mouth because that leg is really, really far away from all of those structures. You probably will lose the hair of that area, and maybe you could have some indigestion, but overall, think like at a one area, because radiation is ultimately a what do they say, topical? I want to use the correct term here. Local. Yeah, it's mostly a local form of cancer control. And then brachytherapy. Okay, now radiation with an external beam is a machine that kind of blasts the person. Brachytherapy is a little radiation bead that they just put in an area and let it sit there, and it just constantly shoots off radiation, which will constantly destroy something from the inside. Now, this works great as long as the seeds stay there, which unfortunately they don't always. If you see a radiation radiation little seed sitting in somebody's bed, don't touch it with your hands. Don't do that. That is so stupid. Don't do that, okay? They need to be picked up with tongs, placed in a lead-lined container, which the patient should have, by the way, and the patient should know this. If it falls out in their own home, they shouldn't touch it. They should pick it up with the fancy tongs and also wear big fancy gloves. For somebody who has one of these seeds, cluster care, try and make it so that only, maybe you switch around the people that go into that room so that the least amount of people are exposed for the least amount of time. So, all that. Kids should probably not be going into that room when seeds are there, or at least not, like, in there up close and personal, or if they are up close and personal, for a very short amount of time. One hug. You get one hug! One. But, I mean, they are, they work in that one area. They are not good for widespread cancers because it's local. So, there you go. And there's practice questions because we already did them. You will care for many patients who have had cancer in the past or who are currently experiencing treatment for cancer. It can cause long-term effects being heart failure, deafness, increased allergies. Your compassionate whole person care can make a difference. Nursing care priorities. I guess we should have seen this coming. Safety ABCs, and then which body part is being affected. And that's it. That's everything. Boy howdy, I'm so glad this is over. We did a good job. I think we went through everything well. And it was definitely a more comprehensive overview than the last one we did. Thank you so much.